Alright, so let's go ahead and get started here. First, we've got these issues we're going to talk about. Let's go back and look a little bit at the anatomy of the nose and sinuses. Okay, you know, you kind of have to know this normal before you can figure out the abnormal. But these are your landmarks. You see your sinuses here, the frontal sinus, the sphenoid sinus. Let's see. Alright. These turbinates. Does anybody know the function of the turbinates? Humidify. Okay. Alright. Warm. How does it do that? How do the turbinates warm and humidify? Yeah, and exactly. But here's the key. It's going to increase the body surface area for the air to move across. And the body warms and humidifies. Okay? So that increased surface area, that's more surface for the air to have to go across, that is warming and humidifying, basically. Alright? Okay. So now, let's get started here first with sinusitis. Alright, sinusitis is an inflammation of the sinus mucous membranes. It's usually caused by strep pneumonia, Haemophilus influenzae, Diplococcus, or bacteriurides. Alright, this is just a look at a CT scan that will allow you to kind of see some of the sinus cavities that are affected here. Okay. Alright. Now, what do we do about it? Well, it depends on the cause. What's the problem? What's the causing, cause of the inflammation of the sinuses? First, if it's a bacterial type infection, use broad spectrum antibiotics, analgesics for pain and fever, decongestants, steam humidification, and then hot and wet packs over the sinus area. Sometimes helps with the pain as well. Also helps to kind of loosen up and open up those sinus passageways to get rid of some of the infection in the fluid. Also nasal saline irrigants, and then increased fluids. Okay. They actually may do a surgical approach as well. Surgical management would include the FES procedure, or functional endoscopic sinus surgery. This is not something that, somebody just gets a sinus infection once. They're not going to go in and do surgery. A patient that has recurring sinus infections over a extended period of time, and they just can't get the infection knocked out, they may go in and do that. Basically, they go in with a long needle and drain it out. Okay, drain that cavity. It can take as long as 4 to 6 weeks for the mucous membranes to fully heal. And the post-op teaching should include frequent sinus flushes every 2 to 4 hours. Okay. With this procedure, they're going to go in, and they usually go in basically through the back palate. Probably not the correct term, but basically the back of the throat and nasal passage back here. They're going to go into the cavity. What do you think some of the complications might be from that procedure? What do you have to look for? If they're going to take a needle and stick it up through into the sinus cavities here, what do we have to look? Absolutely, possible nerve damage. I mean, think about the anatomy of, where are we working here? We're working in there with, the eyes, the brain. The brainstem is right there, pretty dang close, right? You gotta be aware of that. CSF tract is right there. You could have meningitis that could result. You kind of have to think about that in terms of where are they at, where are they working, and what could be, some of the hopefully they hit the right spot, but if they don't, you got to be aware of that. All right. Next, you got rhinitis. Rhinitis is inflammation of the nasal mucosa, commonly called hay fever. Seasonal allergies is what people will commonly refer to them as. Manifestations, you probably know them: headache, nasal irritation, sneezing, nasal congestion, and rhinorrhea. Okay. I know around here, if you don't have seasonal allergies, you're probably getting them. I mean, it's as the seasons change, that irritation of the nasal mucosa is pretty common. All right, some of the interventions. Drug therapies include antihistamines, leukotriene inhibitors, mast cell stabilizers, decongestants, antipyretics, and antibiotics. We also have complementary medicines that you'll see, the vitamin C, the zinc, all that kind of stuff. The big thing is going to be support the symptoms. It's going to be just the nasty, the runny nose, the sore throats, the fevers, all that kind of stuff. Most of it's not necessarily that critical. It's just bothersome. Something you got to worry about. All right, next we've got pharyngitis, sore throat. It's common inflammation of the pharyngeal mucous membranes. It can be caused by bacterial or viral infection, and often occurs with rhinitis and sinusitis. You've got odonophagia, or painful swallowing, really common. You've also got the dysphagia, or difficulty swallowing. Fever is also a common result. And then epiglottitis can be a rare complication. Okay. Now, pharyngitis, commonly referred to as sore throat. Right? Depends on the infecting mechanism, or the infecting bacteria or viral agent. But with a group B strep group A beta hemolytic strep infection, that's what you commonly or typically refer to as a strep throat type infection. Okay. Now, treatment. Well, I guess this is more of a complication that could occur. Peritonsillar abscess is a common complication of acute tonsillitis. It's an infection that spreads from the tonsil to the surrounding tissue and forms an abscess. Most common is the PTA of a peritonsillar abscess is group A beta hemolytic streptococcus. Manifestations include pus causing one-sided swelling with deviation of the uvula, trismus, difficulty breathing, bad breath, swollen lymph nodes. Depending on the type, you're usually going to try to go in and drain it. Okay, percutaneous needle aspiration of the abscess. Usually they're going to try the antibiotics first. If the antibiotics work, then they hopefully would not have to go in and drain the abscess. Okay. Does anybody know what the trismus is? Ever heard of trismus? It's when patients are just constantly chewing. They just look like they're chewing on something. You look in their mouth, there's nothing there. What are you chewing on? Well, basically they're filling that abscess, and they constantly chew, think that something's in their mouth. And here's just a look at a peritonsillar abscess. And this one, obviously this is going to be an abscess. Can't really see, but I think this one may have bilateral abscess. That kind of looks like you may have if it's not an abscess, it's the start of possible infection on the right side as well. But definitely on this left side, that's a pretty good size abscess. All right, next we've got influenza. This is a highly contagious acute viral respiratory infection. You all should know it by now. 5 to 20% of the U.S. population develops influenza each year, and it results in an estimated 36,000 deaths each year in the U.S. alone. That's why you hear about it. That's why they really push the vaccines. Now, these 36,000 deaths, who do they normally occur in? Okay, the elderly, probably children. Those are the ones that are going to be the most at risk. Okay. It's contagious from 24 hours prior to the first symptoms, so that's a pretty key point. Kind of a scary thing. You don't even know you've got flu for 24 hours, and then up to 5 days after the symptoms begin. Okay, that's why it spreads so easily. Most people don't know they have it until they've already spread it. Vaccination is advisable. Antiviral agents may be effective. Now it depends on when, how quick you catch it. But Tamiflu and Relenza, common antiviral agents that we'll use. Common clinical manifestations are going to include the muscle aches, fever, chills, fatigue and weakness, anorexia, and sore throat, cough, watery nasal discharge. These all will typically follow the initial symptoms and can last a week or longer, even after the patient really doesn't have the flu anymore at all. And what do we not see on there? Do we see GI You know, it's not a GI bug. And you hear, I had the stomach flu. Well, that's something different. Okay, it's not going to be the influenza. It's not the real flu. But you get the point. It's going to be the respiratory, the muscle aches, and the fever. That's what you really see. All right, now, pandemic influenza, and this is what we've kind of been dealing with in the last few years. It's mostly prevalent among animals and birds. Virus can mutate, becoming infectious to humans. You've heard of the avian bird flu, the swine flu, the H1N1 swine flu we had a couple years ago. Now, with the pandemic influenza types, they may go into strict isolation precautions. And usually, with those types, we're going to have the actual TB respirator, or at the very least, an actual surgical mask. And, you know, for regular flu as well. But definitely with these, they commonly go even further and do the TB respirator. The treatment is still going to be with antiviral drugs and the management of symptoms, including the Tamiflu and the Relenza. Really, the care is not going to be much different. You know, you should be careful with just the seasonal flu, but the pandemic influenza, they really take some precautions. All right, next we've got laryngitis. Laryngitis is inflammation of the mucous membranes lining the larynx with possible edema of the vocal cords. Acute hoarseness, dry cough, difficulty swallowing, and temporary voice loss or aphonia can occur, or most commonly occur. It's also commonly a manifestation of other problems, including throat and lung cancer, exposure to irritants and inhalants, such as tobacco, chemicals, and smoke. Also, vocal exhaustion. By the end of today, I probably will not have a lot of voice left. Hopefully, it'll come back by Wednesday. Gastric reflux. Okay, gastric reflux is the acid reflux comes up. It can damage the vocal cords. And also intubation. Okay, patients are intubated. They can damage or even irritate the larynx. All right. It could also be the result of upper respiratory illness. This is probably the most common. Treatment is going to be focused on the relief and prevention and elimination of the source of inflammation. So what's causing it, that's what we're going to try to treat. This includes voice rest, steam inhalation, increased fluid intake, throat lozenges, antibiotics, and bronchodilators. You want to teach patients, this is a key point, teach patients with recurrent issues to reduce the use of alcohol and tobacco. But the key, we're going to eliminate the symptoms by hopefully eliminating the issue. All right. All right, next we've got epistaxis. What's epistaxis? There you go, nosebleed. Fancy name for the nosebleed. Nosebleed is a common problem, and then cauterization of affected capillaries may be needed. Commonly, this is going to be patient goes in for some type of surgery or procedure, continues to bleed after a certain period of time, they may have to go in and cauterize. Usually, this is not just your seasonal allergies cause some irritation, and we're going to have to go in and cauterize. That's usually not the way that works. But posterior nasal bleeding is an emergency. What's a sign, a typical sign of posterior nasal bleeding? Okay, if I've got a patient that comes back from a procedure, okay, so drainage, so what's going to be the sign that you look for? Okay, spitting up blood, yeah. If they're spitting up blood, absolutely. But what's a subtle sign you may look for? What if they're frequently swallowing? Yeah, they may swallow and not even say, I got bleeding, you know, I'm spitting out blood. And sometimes it's subtle. But anytime you got a patient post-op and they're just sitting there swallowing constantly, I know my background in peds, kids a lot of times they're not doing, they're going to tell you, hey, I got blood in my mouth. They just sit there and swallow a lot. So you have to monitor for that. Same thing following a head injury. Anytime you got a patient that comes back and they're swallowing a lot, it could be blood or it could be CSF. You got to frequently monitor for that. But back to epistaxis. You want to assess for respiratory distress. and also tolerance of packing or tubes. One of the things you'll see when they come back, if they've done a cauterization or they've done some kind of procedure where they had to pack, they'll actually have a string that they'll tape to the side of the cheek. You may have a guess on what that's going to be for. Is that? Oh yeah, retrieve them so we can pull them out for sure. But along those same lines, why would we want to be able to pull them out in a hurry? Airway obstruction. Okay, so say we had to provide respirations, or patients having difficulty breathing. Yank that thing out, and we can put an ambu bag on. If not, you're basically decreasing half your airway if you're only using the mouth. But here's the key: patient comes back from surgery with a string taped to their cheek. You need to make sure that string's attached to their cheek every assessment. Okay, because if not, that packing can actually move back. We definitely don't want that. That's obstructing the airway even more, right? But we want to monitor for that, but also monitor to make sure it hadn't come out, all that good stuff. If the patient comes from surgery and the doctor hasn't ordered you or hasn't taken something out, we need to kind of check on those things. All right. Also with epistaxis, some of the treatment options: humidification, oxygen, bed rest, antibiotics, and pain medications may be some of the treatments. Key is usually it's dry. Mucous membranes get dry unless there's some kind of incisional bleed or something like that. So providing the humidification. It may be that you've got a patient on oxygen. Okay, make sure you got a water bottle. If they've been on oxygen for more than 24 hours, you can at least ask and suggest it. And if you are the nurse, you can go grab one and put it on and hook it up. Don't let them dry out too much. All right, fracture of the nose is displacement of the bone or cartilage that can cause airway obstruction, and that's the key part. Facial fractures, any kind of head injury, can cause airway obstruction. That's what you got to monitor for. A broken nose, yeah, it's not fun, but you're looking more in terms of what does the nose do? Well, it brings in air, which has oxygen in it. It expels CO2, but it also, it's that source of bringing in air. That's the airway. Okay. Now the cosmetic aspect of it, yeah, that's what everybody wants to get fixed and all that. But your concern is that airway obstruction. Okay. And it's also a potential source of infection. Okay. And again, when you've got a facial trauma, you're close to the CSF and the neurological system, right? You also got to take that into consideration. It's real easy for that bacteria to move and become meningitis. Okay, not fun. CSF may indicate skull fracture. So the frequent swallowing may be blood, but it may also be CSF. You want to examine. Even if it's just a sputal specimen, get it and make sure there's not glucose in it. What does glucose indicate? CSF, spinal fluid. Okay. So some of the interventions with fracture, maybe a closed reduction, rhinoplasty, nasoseptoplasty. You don't have to know the specifics of these. Just know how you take care of them. Okay. Know how you take care of them post-op. When they come back, what are you looking for? Here's a look at a patient following a rhinoplasty. Okay. This is your common splint and mustache dressing. Okay. Which one's the mustache dressing? There you go, the one below. It's designed to catch the secretions that come out. You're gonna have some bleeding. You're gonna have some drainage. You do need to monitor that drainage to make sure it's not CSF. One of the ways you can, we said glucose. You would test it for glucose. You can also look at the bandage. Okay, if you've got drainage that's coming off onto the dressing, and it's CSF mixed with blood, usually it's going to develop a little halo around the outside of the drainage. It's just kind of like a little yellow halo. That's a pretty good sign that you've got CSF. One of the positive signs is going to be the glucose testing as well. Now, this picture started out laid over on its side, and I flipped it up. Does anybody have a guess on why we flip it up? Following a rhinoplasty? Well, yes, so he can breathe. Drainage, okay. What about, there you go. And also swelling. We want to keep the head of the bed elevated, okay. We don't want them laying flat. Okay? We don't want them, laid back with all the drainage and all that, but also swelling. Keep them upright so they can breathe, but also so that swelling does not occur. And again, that could also impede the airway as well. All right, so keep the head of the bed elevated unless there's some type of other contraindication, which may exist, especially with a patient that's had a fracture, some kind of trauma. They may be on straight flat precautions, but if not, keep that head of the bed up. All right. Now, other facial trauma. Again, priority assessment is going to be airway. Anytime you're dealing with the face and the head, you got to worry about the airway. Some of the manifestations of, impaired airway, you're looking for stridor. What's stridor? Yeah, it's a step up from a wheeze. Okay, and a wheeze is impaired airway. Stridor is when it's almost closed off. I mean, there's not much moving. It's a eerie sound. All right. Also, shortness of breath and dyspnea. You want to know. I mean, if the patient's struggling to breathe, you've got to figure out what the problem is, and get some oxygen to them. Anxiety and restlessness, again, could indicate impaired airway. Hypoxia and hypercarbia, so decreased tissue perfusion, but also increased what? What's hypercarbia? Too much CO2. All right, so hypercarbia. Also decreased oxygen saturations, cyanosis, and then loss of consciousness as well. Okay. Here's a look at some of the types of fractures they'll have. Lefort fracture, type 1. You've got a nasoethmoid fracture. Occurs here. Type 2. It's maxillary and nasoethmoid complex fracture. Type 2 occurs here and across the top. And then type 3 is a fracture passes through the nasofrontal suture, okay, the orbital wall, and the zygomatic arch. Okay. And then it goes right across there. I mean, as you can see, you don't have to know these different types. Just know that these Lefort fractures and these facial fractures, they could easily impair the airway, the ability to breathe, and